Everyone, greetings and welcome to the first edition of the IJME Authors Webinar Series. This is planned as a platform where authors in the Indian Journal of Medical Ethics will have a space to present their ideas on the paper that they have published and initiate discussions among all the participants who are there in the webinar. And it is also planned to have people to give their inputs. We are planning to invite discussants for each of these papers, author webinar series sessions, in which the discussants will give in their unique insights about these papers that are being discussed. And basically, the idea is to increase the discourse and engagement with the high quality scholarship that gets published. And in today's series, this is the first in the IJME Authors Webinar Series. And in this, we are going to be reflecting and discussing two papers, both of which have been related to dialysis in low resource settings in low and middle income countries. And we are going to be looking at the ethical issues in these in carrying out dialysis in low resource settings. Before we go into the details and introduction about the two papers, I'll lay out what is the plan of this evening's webinar. First, we'll have a brief introduction. That's what's happening right now. And then we'll have a brief introduction by Supriya. Supriya is here with us, and she and some of us together have put together the South Asian bioethics community. And so Supriya will make a very brief presentation about what is this community, and she'll introduce the community to the group. And then we will go read these two papers. We'll invite the authors to present these papers, and we'll roughly spend 15 to 20 minutes with each of the paper. And in the after the papers have been presented, we'll invite the discussants. The discussants will share their remarks. And after that, we'll have an open house, brief 15 to 20 minutes open house, in which we'll have audience and people who are participating in the webinar. They can give their comments, ask questions. So that's roughly how this webinar has been laid out. And we'll first, I first invite Supriya to please give a very brief introduction about the South Asian bioethics community. Supriya.
Yeah, thank you, Vijay. First of all, I would like to thank Amar and IJME team for this opportunity to share about the SABT community, which we are calling right now, and to give you all a very brief overview of South Asian bioethics community. So this is a community which we set up with the explicit aim of bringing together peers from like South Asia who work on healthcare, ethics, and related field, of course. And our main goal is to create a space, especially for critical conversations and an opportunity to network, particularly for early career scholars, and learn with each other and about each other, and also about through the experienced scholars too. So the meeting will be held on third Thursday every month. I mean, we are quite aspirational in that sense. Our current activities are reading sessions and panel discussions. I think last week, a week before we had first reading session. And this coming up, I mean, I think in Feb 19th, I guess, we have another session, which is a panel discussion. And also around feedback activities, like people who are working on any of their current drafts or something, which is whether it's even master students or even postdoctoral scholars on their working papers, we are inviting and we are brainstorming about their ideas. And so basically a quick overview of the organization which we have, which is still a small community, as I said. We have 6 core working group members, and who are all early career scholars from different institutions from India and Pakistan currently. And we do not have any central funding or anything. We adopt a rotating leadership where each working member will take up a coordination role every 6 months or even 1 year. And more importantly, we are relying on a voluntary work of enthusiastic scholars to develop and be part of this early career scholars community and South Asia community. So as I said, it's a very small and growing community. Currently, we have 15 plus members. If you're interested to join the group, please fill in the membership form, which I'll just be sharing soon. And if you want to even organize any activities, please do reach out to us. So lastly, I'm very thankful for IJME for supporting this opportunity for the SABT community. Amar and Veena particularly, who supported this initiative. And so this almost sounds like a sales pitch, I feel. I hope I did a good job on that. And I really look forward you all to join us. And I'm excited to today's webinar's discussion. So yeah, thank you, Vijay.
Thanks, Supriya. Thanks for that very crisp and interesting introduction about SABC. The previous discussion of SABC was, we read a paper on female genital cutting and the ethical issues related to that. And it was a very exciting discussion. We had a very rich round of discussions, and thanks for putting this whole thing together, Supriya. And so with that, we will move into the proceedings, the main proceedings of today's webinar. We'll be reading two papers, both of which have been published into the in the Jan to March 2023 issue of the Indian Journal of Medical Ethics. The first paper is the indirect costs associated with free pediatric hemodialysis, experiences from Karachi, Pakistan. We have our colleagues, Professor Ali Asghar Anwar Lenwala. He is a professor, Department of Pediatric Nephrology at the SIUT, Sindh Institute of Urology and Transplantation in Karachi, Pakistan. And accompanying him, his co-author is Sualeha Siddiq Shekhani, a very active member of SABC. And Sualeha is assistant professor at the Center for Biomedical Ethics and Culture, SIUT, Karachi, Pakistan. They have put together a very interesting empirical research paper, which is a mixed method study, which is looking at pediatric hemodialysis patients, and they have looked at the costs associated with it and the burden of costs associated with it. Without much delaying much time, I would like to invite Dr. Ali and Sualeha to please take over.
Thank you very much, Vijay, Amar, Mala. We all know you very well, and we're really excited to be here. Thank you for giving us this opportunity. So what I'll do is I'll take you through my paper, the paper that we both wrote. It was basically part of my MBE thesis that I was required to do while doing my master's in bioethics at CBEC. And this was a mandatory research, and I had to come up with some kind of topic which pertains to my clinical expertise. And this is something that has been troubling me for some time now. I'll briefly give you some of my background training so to put into context why is this issue now so close to my heart. I did my MBBS from a private medical college, and with all my other colleagues, I went to US immediately after my graduation for further training. I trained there for 6 years, and then I came back and joined SIUT. SIUT was a completely different experience for me because I had been always exposed to a private setup and mostly healthcare that is being provided to people who are more privileged, and usually resource constraints is not an issue. And then 2 years after I joined SIUT, I also got an opportunity to go to Sweden at Karolinska Institute, and I stayed there for 3 months, and I closely observed how hemodialysis patients and the nephrology transplanted patients are being treated there. So when I returned there, now it's been almost 18, 19 years that I've been working with families and children here, where all the healthcare facilities are provided under one roof and completely free of cost to all the patients. When we say free of cost, means that we have no cash counter, and anyone who walks in can get whatever treatment, be it dialysis or transplant or any other treatment. It is completely free. So that's why we attract a very large volume of patients. And when we tell the number of patients that we see in a day, most of people think that either we are lying or we are just delusional. You know, it's not possible to see that many patients in one setup. But we were always very happy that we could do something good for our community. However, the dropout rate of dialysis, even when everything is completely free in terms of monetary thing, the dropout rate from dialysis in both adult and pediatric population is significantly high. And that is what has always troubled me, that why is that so? So this study was carried out just to explore and see what kind of lives that family goes through, what kind of burdens do they share. The whole family takes for one person in that family who has to take maintenance hemodialysis. So this was basically the rationale of this study, in which
we lost connection with are they still?
No, they're not there.
Hmm.
We lost the connection.
We'll just give them a couple of minutes and then.
Do you have their WhatsApp number or something like that to call them up on WhatsApp?
Let me just check.
We dropped.
Yeah.
So we'll just,
okay, so that one questionnaire that I filled, and then there was one anxiety depression screening pro forma, a questionnaire that has been validated in our population, and that I used to screen them if they would have any symptoms of anxiety and depression. And but after doing those interviews, I identified two cases in which I did an in-depth interview with two of them, and to get more of their perspective and more details about their family lives, because I thought that they would have, it had more context and more, I would say, depth in trying to get to identify what that family goes through. So what we found that even they don't have to pay anything for the treatment of dialysis, and the family has to pay a significant amount just to commute back and forth to the hospital. One of the main reasons was that the distance that they covered to get here was very long. In majority of patients, they were traveling for more than 50 kilometers. And since the infrastructure of our city and the public transportation is not very conducive for patients who cannot really easily hop up into the buses or, stand at the bus station. So they would take a small taxi or a rickshaw or that kind of conveyance, which would cost them much more. And the time that they would spend just coming to the hospital, waiting for the time to get dialysis, and then a dialysis session and returning back was almost equal to one working day. And for children, when a caretaker brings them for dialysis, that means that not only the child who is getting dialyzed, but also that one family member has to spend a whole day out of their whatever responsibility place, like a workplace or home, even a homemaker mother with other children at home would have to spend those at least 2 whole days of the week outside her home. And in that situation, when she's away, all the other chores and the care of the other siblings who are otherwise healthy, that all gets disrupted significantly. So this is what we found, that this exact cost of coming to for dialysis was very high. And only those families could sustain this treatment where they would have some kind of other support back home, because if one of the parents would leave home, then either they would have another source of income, or if the mother comes, then either a grandparent or other older sibling would take over all the responsibilities at home. In some cases where there were not enough family members who could pitch in, there were even neighbors or friends or even landlords, some other person at home who would take care of those responsibilities while they are away. Second thing that we found was, and that was perhaps one of the very important reasons for them to be able to continue their dialysis, because we assume that those who would not have this kind of support would ultimately burn out and would drop out from dialysis because otherwise it's not manageable. And that has been reported in other low middle income countries too. Okay, and the other important thing that we found was that there were about a third of our patients, of the caretakers of our patients, who were primary caretakers, and because of all these crises in their family, 1/3 of them had somatic symptoms of anxiety and depression. They would be complaining of frequent headaches, lack of sleep, but that was not significant enough that would hinder their daily responsibilities or work responsibilities. Only a very few of them had severe enough symptoms that the psychiatrist thought that they may benefit from some kind of therapy or treatment. But only 1 or 2 such caretakers were so seriously symptomatic that they actually required they took some kind of treatment, especially in terms of sleeping and some thoughts of depression. And interestingly, there were a lot of, when I specifically in that questionnaire, there was a question that, do you think about killing yourself because all the situation is so so difficult? So they almost all of them, actually all of them, none of them were having these suicidal thoughts. And when we went to the literature looking for these coping mechanisms to find out that, what helps these people to go through such serious conditions, living conditions, and we are still not sure what helps them here. Even a simple, a chronic skin condition in a child has been reported to give more than 1/3 of these caretakers to have anxiety and depression. But here, with these kind of serious illnesses, when the child unpredictably can have seizures or shortness of breath because of the volume overload that they frequently get from dialysis while being on dialysis, these people do cope with their stresses very well, and that needs to be explored further by other qualitative studies. So the recommendations that we came up with after studying.
Can I just?
Sure.
Yeah. So I mean, I think Dr. Ali has really highlighted the key findings of the study that he conducted, and where I come in essentially was I come from, of course, a bioethics background, but also from a health policy background, and it was always a huge, like, you know, this idea, this understanding that, you know, the social and the economic costs of dialysis and these life-sustaining treatments are so high. And Dr. Ali would often come over here and talk about, you know, this patient dropped out, and, you know, initially, even though, you know, family members vowed that, you know, they will continue with the treatment. So I think, so from a health policy perspective, when we are pitching in huge amounts of resources which are being diverted to dialysis and a free treatment is being provided, but what the findings of the study illustrates that despite this free treatment, there are huge indirect costs which may make themselves to economic evaluations, but that's something that clinicians and nephrologists, I don't know whether they consider it in practice or not, and it becomes eventually you realize that there's a high dropout rate, and it could be because of these indirect costs, this opportunity cost of losing work when you're here twice a week getting dialysis done for your children, right? And this general geographical inaccessibility. So SIUT is located in a particular part of Karachi, and it's a very busy area. So where are other people coming from? So one of the things that SIUT did eventually was to open satellite centers in different parts of the city to offer these dialysis services. This may have helped a few people, but we know that this is keeping in consideration the huge familial costs. And we illustrate this through case studies that are mentioned in the paper, where a lot of family members have to actually chip in to provide resources to sustain this life-sustaining treatment, which is extremely hard for them. And this kind of brings the moral question, you know, and the other paper actually alludes to it as well. And this brings forward this moral question, whether to clinicians, as clinicians, do I have the responsibility towards just the patient sitting in front of me, who is the pediatric patient, okay, and whose parents are making decisions, medical decisions on behalf of him or her, or do I have to consider the impact on the family and social unit? Because I know that what will be happening to the family once the dialysis is initiated. Do I offer the treatment in the first place? How much do I actually end up telling about it? Because, and keeping in consideration that the dropout rate will be high. And I think this of course will extend to other parts, but, you know, clinicians report feeling guilty, you know, when they're offering treatment options which are expensive. But even in this case, if this expensive treatment option in Pakistan is provided for free, so do these treatment options, are they really options for such patients in such poverty? And we know that people experience catastrophic health expenditure because of this treatment, even if it is subsidized, for in the case of India or Indonesia, for example. And then, you know, the chronic illnesses and the treatments have far-reaching consequences for the families, and that dialysis, this offering of dialysis presents moral dilemma for the family members itself, right? I mean, they have to decide that this is the amount of scarce resources that I'm going to allot. They have this set of scarce resources, and they have to decide, do I allot this to one person, or do I consider the survival of the entire family unit, right? And in Pakistan, which is a largely collectivist society, you cannot underestimate the importance of family. And while family will have a lot of dark sides, as we illustrated in one of the case studies, where one of the brothers, the eldest brother of the family, actually refused to provide a kidney for transplant, and so the kid had to continue with the dialysis for life, it illustrates that, family may not always be such a protective factor. But over here, one of the reasons we believe also that people continue with dialysis is because there is some social and family support that is coming for them, right? And so from policy considerations perspective, should this kind of life-sustaining treatment be provided for free? And if so, and if it is provided for free, how do clinicians negotiate this dilemma of offering the treatment? And if they do offer the treatment, do they consider the social and social impact on the family? And what about what it does to the overall impact on the child itself? We know that 90% of the people actually in the study dropped out of school following dialysis, right? So is there a way that we can actually involve through a multi-sectoral approach in, for example, in educational programs, for instance? And I think we quote this in our study, and that really captures it, that, development of end-stage kidney disease among children has been described as a life-changing tragedy for the child, their family, and the community. And I think our study illustrated that the impact of dialysis is far beyond just the treatment cost, and it expands into, and it really affects the moral and the social fabric of the family unit. Thank you.
Thank you.
Thank you, Dr. Ali and Swaleha. That's a very crisp and interesting presentation. There were several interesting dimensions that came out in your study, and we will hopefully have time to talk about it towards the end of the webinar. Thanks for sticking to your time. It was bang on. And so we'll move on to the next presentation of this evening. We have a paper by a rather interesting paper which directly flows from what you have just mentioned. We have a paper titled Financial Toxicity and Dialysis, Autonomy and Truth-Telling in Resource-Limited Settings by E.V. Kendall and Rohin Bhatt. And this is a very, very interesting paper. Again, E.V. Kendall is from Swinburne University of Technology and in Australia, and Rohin Bhatt is a Master of Bioethics candidate at the Harvard Medical School, Boston. And they bring in a very interesting health economics and medical ethics, bioethics perspective. And without much ado, Evie and Rohin, over to you.
Excellent, thank you. I'm going to try to share some slides that will just make it easier for us to present, because we're actually presenting from two different locations, of course. So let's see. Can you now see the slides? Yeah, perfect. So I'm going to try and make that full so that we can see it. Okay, so hopefully everyone can see our first slide here. So thank you very much for allowing us to present to your meeting. And it's been absolutely fantastic working with Rohin. So we have some slides prepared because, as I said, we're actually presenting from two different locations. So at certain points, I will throw over to Rohin to continue. So our paper was on financial toxicity and dialysis. So the first thing that we usually do in Australia, this is our tradition, is to acknowledge the traditional owners, so the Indigenous people of the lands where we are gathered. So I'm paying my respects to the elders past, present and emerging of the Wurundjeri people of the Kulin Nations. So this is hoping that reconciliation continues to be shared and embraced. So why this topic? Why is there an interest in financial toxicity and dialysis? And essentially for me, my interest started at the 14th World Congress of Bioethics in Bengaluru in 2018. So I was attending and presenting with a group of people, several of whom I've noticed are on the call. So it's fantastic to see you again. And we were looking at dialysis and resource-constrained settings. And the interesting thing for me was several local nephrologists actually approached me and said, I don't offer dialysis to my patients because I know they can't afford it, and it would be cruel to tell them about something that I know they can't have. And that was a really interesting point because although on the legal side, we knew the situation was, respecting patient autonomy and consent and giving all the relevant options. But what we were actually hearing was, in practice, people felt really conflicted about offering a service that they thought people couldn't necessarily afford. So this sort of sparked the interest looking at, okay, what is the situation here? And as a medical ethicist, what kind of arguments might we put forward? So just a bit of background. I know most of you will already be familiar with this, but just for anyone who isn't, chronic kidney disease has a global prevalence of about 13.4%. So it's actually a massive problem worldwide. And they estimate about 5 to 10 million people worldwide will develop end-stage kidney disease. And we have some of the symptoms on the screen here. So water retention, fatigue, uremia, electrolyte and pH imbalances, and renal anemia. And as we've already heard from our other speakers, end-stage kidney disease and renal replacement therapies are extraordinarily expensive to provide. So the rates are 2 to 6% of health expenditure in places like the USA, UK, and Japan, for example, despite the patients only accounting for 0.1 to 0.2% of those populations. So we also see very large demand increases in South Africa, Mexico, Brazil, the Philippines, China, and India. And that's our main sort of case study today. So this is a very expensive sort of treatment, and it does affect quite a lot of people. So in India, of course, there is a service available to defray the costs of dialysis. So low-income families might be eligible for this support program. But we actually found in Bradshaw et al. Study that for 835 participants in this particular support program on maintenance hemodialysis, 91% of them actually experienced catastrophic health expenditure even after they had the relevant subsidies. So the subsidies exist, but people are still suffering this catastrophic health expenditure. And I was very excited to learn that Dr. Valerie was one of the discussants today as one of the global experts on definitions of catastrophic health expenditure, because another thing we noticed in the study was, of course, every person defines this catastrophic health expenditure differently. So some people were saying it's only if you don't have disposable income after you've paid for your groceries and rent, and other studies defined it very differently. And I can see Charlene is nodding along here. So this is a familiar problem for our other researchers as well. So it's fantastic to have that point of connection there. So I'm going to pass over to Rohin now to talk about the informed consent procedures in India.
Thank you. So the informed consent has been read into Article 21 of the Indian Constitution by the Supreme Court. Article 21 basically says that no person shall be deprived of life and liberty without the due process of law. Again, so the Supreme Court, while interpreting the doctrine of informed consent in the Indian law, has borrowed very widely from Britain. For the purposes of our paper, we stuck to the definition of consent under the Indian Contract Act. I'm told that India and Pakistan have the same Indian Contract Act. So anyway, consent is said to be free when it is not caused by coercion, undue influence, fraud, misrepresentation, or mistake. So says the Indian Contract Act. There have been significant judgments of the High Court and the Supreme Court which lay down various parameters of what informed consent looks like, especially in medical negligence cases. Basically, you need to tell your patients about the benefits, the risks, and the alternatives. Having said that, consent has been held to be informed only when there's adequate information about the nature of the treatment procedure. Can we have the next slide, please?
Yeah.
Thank you. Post the pandemic, we are seeing the disparities between the rich and the poor grow. Now, if you look at the latest Oxfam report, it says that the top 10% of the Indian population holds 77% of the total national wealth. Extrapolate this with the fact that India is one of the countries where every household's out-of-pocket expenditure has always been a major contributor. And of course, the figure has been improving from 69.4% to 48.2% in the National Health and Family Surveys. It's still high. if the WHO figures are to be believed, nearly 55 million Indians annually are affected by catastrophically by out-of-pocket expenditure. And with this background, I think we need to understand that just because patients are poor, it does not take away from their ability to retain and process information. I think one of the conversations that Dr. Kendall and I had was how doctors were not giving the patients the option to opt in for dialysis simply because they couldn't afford it. And so it's important that we kind of look at patients who are poor as being fully autonomous beings with agency, and then give them the right to opt out of treatment if they so desire. Again, we would like to point out that cost or location does not vitiate the capacity to consent. A patient may be poor, a patient may hail from a rural setting, but a patient may still opt in for dialysis, and that I think is an important choice that should be provided to the patient rather than the doctor making it for them.
Okay, so moving on to our definition. So we decided to use the definition by Zafar and Abernethy from 2013 because they coined the phrase financial toxicity to refer to the quality of life impacts of large out-of-pocket medical expenses. And although they were specifically referring to cancer therapies, the same can apply to chronic kidney disease and especially dialysis. We've heard that it's very expensive, and patients sometimes describe it as a form of prison, that they can't have any fun anymore, they can't go on holiday anymore, they can't even necessarily buy the food that they want because they're using all of their income on dialysis. And the question becomes, should physicians discuss financial hardship alongside other side effects of treatment? So if you're thinking a doctor has to provide the profile, the risk profile, and the pros and cons, the side effects and expected benefits of a treatment, should they also discuss these quality of life impacts of financial sort of pressure? We know that there is evidence that assumptions about financial state are impacting referral patterns for dialysis. And this is not just in resource-constrained settings. This is everywhere around the world. So we found reports saying that doctors are not referring people to dialysis for a number of reasons, and that financial status is one of those assumptions. We also found that sometimes patients would then discover the reality that dialysis exists and be very upset that their physicians had sort of breached their trust by not telling them. So that has done some harm to some of those doctor-patient therapeutic relationships. So it's interesting because the cancer is a very good analogy here. It is another long-term, chronic, very expensive to treat condition that tends to impact the whole family. And it's also important because the graduated disclosure that we're advocating for that sort of allows the patient to decide how much information they receive and how much of that financial information they wish to receive as they go through their options is something that's already being practiced in chemotherapy, particularly for unfunded therapies. So implications for autonomy, as Rowan has already stated, of course, people do have the right to knowledge and they do have the right to choose from different options. And it's important to note that plenty of people actually opt out from dialysis for non-financial reasons. So there's no reason to assume that finances are going to be someone's dominant concern when it comes to this treatment. But the idea that if you offer a treatment someone can't afford, you're doing the wrong thing, neglects the fact that you don't necessarily have the right to receive whatever option you prefer. A lot of people on dialysis would obviously prefer to have a kidney transplant, but if there is no kidney available for them, we don't hide the knowledge of transplants from them just because they can't have one. And it's a similar idea here. You wouldn't necessarily want to hide the existence of dialysis or just not refer a particular patient because you think they can't afford it or you're making assumptions about what they might want. So they may want dialysis and still not be able to afford those out-of-pocket expenses, whether they be direct treatment expenses or, as we heard from our other speakers, things like transportation expenses, other household expenses. They're all very important considerations here. we wouldn't hide that knowledge from them because we're making assumptions about what their preferences and values might be. And I'm handing back to Rowan to finish this up.
Yes, and the final few objections that could be perceived as providing false choices, as Dr. Kendall said. Again, this on the contrary, long-term dialysis leads to depression and anxiety, and thus there's a case to be made about how it's not actually improving the quality of life. The next thing is also, as India as a collectivist society, there is a strong interdependence of family and kinship values. And so while it's important, it's also important to account for the fact that most people that we talk about when we talk about in rural resource settings are those that go to government hospitals. In that case, there will probably be one or two earning members of the family. And if one of them has to go and account for and take care of the patient, then you're putting the whole family is at financial risk. And so we advocate that when the patients are given a choice through a graduated disclosure process, it might enhance their autonomy. And extreme poverty has, of course, as Dr. Kendall said, been used as a ground to exclude some patients in resource-constrained settings for chemotherapy. And so there's no reason why it cannot be used to exclude patients for dialysis. Thank you.
Thank you very much. And that's the end. So we very much welcome discussion and questions.
Thank you, Evie and Rohan. That was a very interesting presentation. I'm sure there are a lot of discussion points from this presentation also. We now have discussions for these two papers. We'll hear from them first, and then we'll throw open the floor for discussion. The discussants incidentally have also written a very interesting editorial on this topic in Indian Journal of Medical Ethics. And in the same issue, we have Dr. Priya Pais, who is works in the Department of Pediatric Nephrology at St. John's Medical College in Bengaluru. And we have Valerie, a very good friend of mine. Hi, Valerie, from Department of Nephrology in the University of Children's Hospital in Zurich, Switzerland. Both of them pediatric nephrologists, and they bring in their perspective, and they have written a very interesting overarching editorial in the IJME covering these two papers. Over to you, Priya and Valerie.
Go ahead, Priya.
Hi, Valerie. Thank you for the kind introduction, and thank you also for inviting me to be a part of this, and for the very interesting papers that were presented. So I don't know how much of discussion I'm going to do, but I thought I would maybe share a little bit of my experiences also, and maybe add a little bit of my own perspectives and how they are similar in some ways and slightly different in some other ways. So as you said, I'm a pediatric nephrologist, and similar to Professor Ali, I did my medical training in India and then did my specialist and pediatrics training in the US. So I was there for about 12 years. And I had the chance to work for a little while and then returned back to Bangalore. So one of the reasons why I got interested really in this arena was the difference in outcomes of the patients with kidney failure that I saw in the US and then encountered in India. There was, I think has already been mentioned, the level of care and the dialysis that was offered, the diagnostic techniques, the transplantation, everything was available in the center that I worked at, similar to the centers in the US that I had worked at as well. But we had so many patients, similar to the experience, I think, of Professor Ali and his team, that patients just disappeared. And in my setting where pediatric nephrology services are really hard to come by. They're not easily available in India. A child who discontinues therapy dies. And so therefore, these outcomes were much worse than in the US, where I barely remember maybe 1 or 2 patients in my whole 12 years there dying of kidney failure. So I started, I think, thinking about these issues quite a lot more. And my center is not a center that offers free dialysis. I wish that were possible, but it's certainly low cost as well. And so I think in the first paper, it really highlights how much the burden that a family with kidney disease, a child with kidney disease is burdened, and their family is burdened as well. And of course, in your center, the dialysis is provided free. So it's not just the burden of cost, but it seems to be this massive burden of care. It's difficult for the entire family, whether it's travel costs, it's lost income, it's burden on other siblings. And so therefore, I think that the entire family struggles. I think, as you pointed out very correctly, dialysis is a very expensive treatment. I'm not sure why it's so expensive. I think it's most of our children are on this form of home dialysis called peritoneal dialysis that is done at home. But whether it's hemodialysis or peritoneal dialysis, I think maybe it's just unnecessarily expensive, and it's certainly expensive to the government that pays for it. And in my setting, it's expensive to the families that have to pay for it as well. So of course, the cost is one big aspect of the burden. I too, struggled, and I think we were at the same World Congress of Bioethics, where what do you advise a family when they come to you with a child with kidney failure? And as I'm sure that the clinicians in the group would realize, that what you say determines how the family makes a decision. Because in our setting, the physician and the healthcare team plays a large role in decision making. I think the families are just a little overburdened with trying to decide what to do with this new life-changing diagnosis, and then to decide about the treatment, and then dialysis sounds really frightening. And then they have to learn about the costs. And so they look to physicians to help them make this decision. And I think the role of the physician and the healthcare team, whether it's the dialysis nurse or the social worker, to help the family sort through these options that they have, is really what would help them make the right choice. It's not a disclosure only of the disease details or only of the cost details, but I think also a little bit of moral support in saying that we are here with you and we will help you decide. And so, of course, in India, unlike I think in high-income countries where there is a social support system, in India, if the parent refuses therapy, there's nothing really that we can do about it. And they will leave with the child, and most likely the child is going to die if they refuse dialysis. And so we are faced with that reality as well. So most often our struggle really is not, at least as a nephrologist who's trained to dialyze children, is not about should they have dialysis, but more often, if I can provide the dialysis and I'm really ready to provide the dialysis, I think we usually also have people who can even give some financial support. But if the family refuses, how could they refuse such a life-saving treatment? And I think maybe the answer lies in what issues both papers have brought up about the burden and the difficult choices that families must make when choosing whether to invest all their resources in one child with a, let's face it, it's a lifelong, life-limiting disease. So I'm really glad that you have looked at the indirect costs and the burden, because everybody knows about it. It's like the elephant in the room. It's all known. It's just a social problem. But unless we start talking about it, sharing it, measuring it, publishing it, it doesn't really I think, get shared, especially in the pediatric arena where children with kidney disease are quite rare. With regards to the second paper, I think it's a great, great paper to look at the importance of rights to decision-making. And I completely agree with both of you that patients must be given all information. And I think in my setting, at least, after the diagnosis, the next thing that patients always ask is how much it's going to cost. So we do have to disclose that. So I think that cost aspect and its disclosure is just part of care. We have to do it because they need to know how much it does cost. The question also comes, I think, is do we disclose how much of an additional burden it is beyond the actual, say, direct costs of care? And that's a very difficult question that I also struggle with. Do we straight up tell them that your life is going to be very difficult and you're going to suffer a lot? Or do we say, let's begin and then you see how it goes? I think because we have families who, some of them have no regrets. Some of them take loans, some of them lose a lot of property, but they have no regrets that they tried. And there are families who I think feel that definitely the disease was a terrible curse on their entire family. So that's very difficult to decide how much to disclose of the additional burdens other than cost. So that's my 2 cents about both papers, and I'm interested to hear what you all have to share and what Valerie has to say as well.
Valerie?
So thank you very much, and thank you also for inviting me, and thank you for the very excellent presentations and the interesting papers. I'm just thinking we probably don't have too much time, but I'm happy to just give my thoughts. I'm based in Switzerland, but originally came from South Africa, and through the International Society of Nephrology, I've had a lot of privilege really to interact with a lot of colleagues from Africa, have actually worked a bit there and realized all these same problems. And what we've tried to do is gather data for advocacy, which is exactly what Professor Laniwala has done in his fantastic paper. I'm now quoting this paper all over the place because this is what one needs. One needs really numbers to be able to go then to policymakers, to funders, to parents even potentially, to be able to give a more realistic picture of what actually the reality is. I think that session that Evie mentioned that was in Bangalore actually grew out of a previous discussion we had in one of the ISN summit meetings about ethics of end-stage kidney disease. And Dominique Martin, one of your colleagues from Australia, was saying that autonomy is critical, and almost everyone in the room from a lower income setting was kind of saying, but how autonomy is fine, you want to respect it, but does autonomy really exist when someone doesn't have a choice? And I think that was really what I find is extremely interesting. I think, as Priya mentioned, as clinicians, one does tell patients, and I think now it would be extremely naive to assume that patients do not know that dialysis exists and that patients do not know that it costs money and that people stop. So, I think a lot more is known in the community about dialysis and about kidney failure than we tend to think from our sort of academic enclaves, So there is a level of naivete there because I think patients and families are extremely wise and they know a lot. I think one of the issues that I find really interesting, and this is why I really like, the center in Karachi, is that they can really prove that when you provide just the dialysis, that doesn't fix the problem. And so this is what's critical that governments understand. And for example, I was recently at a meeting with some English nephrologists, and they said that 40% of the entire transport budget of the national health system goes to transporting dialysis patients to and from dialysis in the NHS. In England, they get dialyzed 3 times a week, but that's enormous. If you think of the entire country, these people are 0.1 to 0.2% of the general population, and they're consuming 40% of the NHS budget just for transport. So these are enormous problems that high-income countries are getting around by providing transport or subsidizing transport or allowing it to be deductible from taxes, etc. I think wherever there's a social worker, usually we try to involve them. They generally do speak to the family about everything. Another thing that I feel we should be probably having more of, and they may exist, I don't know, in India, are support groups where parents tell each other what they've gone through, or families tell each other what they've gone through, because they definitely are much more informed than we are as the healthcare people. And I think we also then need to advocate for palliative care if we can't provide dialysis, and that really needs to be able to be given absolutely everywhere. So that has to be a very strong point of advocacy. And I think just 1 or 2 small critiques, I think to compare kidney disease to cancer, there are some parallels, but there are a lot of non-parallels, because kidney disease doesn't go away. For cancer, it's very often people that are, on a treatment for a period of time. So people tighten their belts or hold their breath. Also with cancer, I think people understand that there are extremely expensive medicines that many other people are also not getting. Whereas with dialysis, often people see there are a lot of people getting dialysis, sometimes subsidized, sometimes certain charities, etc. So there are an enormous amount of inequities. So for me, I just find there is no answer specifically. I do believe that patients are being told about all the costs. I think your system of sort of suggesting that you say, shall I tell you only about the cheap treatment, or should I tell you about all the treatments? I struggle with that a little bit, because I think even there, you're not telling then everybody about everything. So I'd just be interested in your thoughts and in other people's thoughts. But thank you again, for inviting us, because I think this debate is extremely interesting and needs to continue. So obviously, I think all of us would be happy to keep working on this together.
Thank you, Valerie. I think we can take a few minutes to both the set of authors to respond to the discussants' comments, and then open the floor for discussions with audience. So would Dr. Ali and Swaleha like to respond to the discussants' remarks?
Thank you so much, both of you, for the wonderful comments and the critique, and it's very useful. And and the experiences from India clearly mirror what we experience in Pakistan. And when you talk about, when the second paper was being presented, there was a couple of points that I was talking about, but you actually pointed these out. In Pakistan, physicians enjoy such a huge amount of authority, which can be really problematic and can be regarded as paternalistic in bioethical debates. But they become part of the family in a lot of ways, and people do look to physicians in making medical decisions, right?
Right. So it's mostly, a very famous phrase in our patient population is that up is the God, and down here are you, the doctor. You are the one who is going to take care of us. We depend on you. You take that decision for us. Whenever we present them with options of treatment, they say, what will you suggest for us? For all that autonomy and all these principles of bioethics, they just don't work exactly in our culture, in our population.
Which is not to say that this does not have a flip side. Of course, physicians are likely to abuse this kind of power that emerges, and we're saying that it probably, it definitely happens. And it's not really the poverty that really becomes the lack of choice, but I think in our settings, it's really the survival of the entire family unit that kind of becomes the major challenge, where the head of the household will have to decide whether I choose one child or whether I choose the other 10 children that I have to feed. And a lot of times, because kidney diseases are often genetic, And so there are a lot of other accompanying medical issues already. And in one of the papers that again, Dr. Ali and I co-author, which was published in Seminars in Nephrology, we illustrate a case study actually by talking about how a pediatric patient with multiple comorbids, her family simply refused transplantation because she said that she just could not cope up with this. Now, are we going to paint? The options were clearly offered to them. You know, dialysis was initiated because at SIUT we have this policy that no patient will be denied treatment, right? But dialysis was initiated, transplant was provided as an option, but the mother still said no, right? No, I don't want to continue with transplant, and the patient eventually passed away. And Dr. Lakes interestingly talked about, you know, whether there's support groups. There are no support groups over here, but you would find that people would be talking in the waiting room. Families would discuss extensively in waiting rooms about their problems. So I think that kind of acts like a support therapy in Pakistan.
And I can quote so many stories where, you know, in that waiting room, they developed relations, and one of them were able to provide job for the other father who was struggling to get a job, or they would be counseling each other on cheaper ways to get around, or, you know, simply other dietary counseling that they provide to each other and they share with their own experiences. So yes, this support group thing does exist. I mean, it's in human nature. However, there is no formal thing for the dialysis. However, for other chronic diseases like Down syndrome, and there are other societies that are now coming up, especially for differently abled children. And all these parents have got together and they've got funding from philanthropists, and they're working very well in that way.
And I think in Pakistan, we just cannot really underscore the importance of philanthropic and donations and people really contributing on the personal effort. So with when Dr. Lakes was talking about the transport subsidy, which is a huge issue within the context of Pakistan, which emerged in our study as well, this geographical inaccessibility and this problem of actually spending so much on transport, and transportation costs are exponentially high, especially, and they've gotten higher in recent years. I mean, you know, there are people who would pitch in for one patient. They have taken upon the responsibility of a patient and actually said, you know, I'm going to fund each and every dialysis visit to the hospital. But those are great examples of you trying to make sure that one person is getting life-sustaining treatment. But from a health policy perspective, and I'm bringing that angle in, it's all of this is great, but ultimately, what is the thing that we're looking at towards the end? What is it at the end of the road? Because these are individual efforts, right? And we advocate for multi-sectoral approaches because health cannot exist in a vacuum. But unfortunately, within Pakistan and other lower middle income contexts, I don't see that this bridging between different sectors kind of happening with education and health, with transport, because dialysis is not just a health issue. I think it's a broader sectorial issue.
There's a flip argument for what Swalia just mentioned, and Dr. Priya also, Pais also alluded to, that, you know, the emotional value for the parent to provide that treatment for that ailing child I mean, there is no objective value to that emotional aspect. You know, there are so many parents that in our practice also would have spent almost everything they have, and but yet they have no regrets, and they're very happy for every, you know, the physical condition that as a third person would be looking at that child who's oxygen dependent, who's wheelchair bound, or can't even sit in some situations, yet the parent is very happy that they're still alive and they could do whatever they can in that condition to keep that child alive.
So over to you.
Thank you, Dr. Ali and Swaleha. That's now. Can we have Evie and Rohan share your responses?
Absolutely. So I'll go first and I'll hand it over to Rohin. So thank you so much for the points and the discussants. Obviously, they're fantastic. Very sympathetic, of course, to the challenge of whether you disclose the indirect costs of a treatment and whether that's the physician's role or whether it's someone else's role. So yeah, absolutely a challenge that quite a few people mentioned in the literature. Some were saying that they were not responsible for disclosing things that weren't medical costs, and others were saying, no, you should bring it in as well. And in terms of Valerie's point, yes, absolutely agree. Cancer is not a perfect analogy, of course not, because it does tend to be time bound. At least ideally it is time bound. People either recover or they don't. Doesn't tend to be the same thing. So it's been drawn as an analogy mostly because it's the chronic condition that's incredibly expensive to treat. And because there's so many different levels that you can attain in that treatment if you have financial empowerment to do so. So of course, in the graduated disclosure, it's not about not telling people that dialysis exists, because as we know from the real examples, people will find out. So many people around the world have access to the internet. It's just about any patient is going to have some access to the internet, regardless of where they are. So they will be able to find this information. And then, of course, it becomes that issue with the doctor-patient relationship that they feel like this should have been actively disclosed to them. But in terms of like what level of detail does someone want? Do they want to know that dialysis would be 3 times a week or twice a week, or where it would be or how long it goes for? If they've already identified it as an unattainable treatment, you might tell them, okay, there's a machine, it does this. Do you want to hear about it? This is the costing. And they might just say, I don't want to hear about the details of that. I don't really want all those details, or at least I don't want them today. So a really important part of the graduated disclosure is you're constantly checking back in with that patient. And of course, that is a privilege right there, because you've got to have access to the patient long term. And as we've already heard from our other speakers, the patients drop out and you lose track of them, and then you perhaps don't have that opportunity to follow up and say, okay, would you like to hear about it now? Has your situation changed, or do you simply want more information, even if your financial situation hasn't changed? So it's a really interesting point. But I also wanted to very quickly acknowledge the fantastic points from the other speakers as they've been responding, particularly that idea of autonomy, and Valerie mentioned that as well, that it tends to be used as a bioethical principle in a way that is not conducive to more collectivist cultures. And absolutely, that's correct. It's been identified by many bioethicists, of course, but it also doesn't work in individualist cultures either. So it is really not fit for purpose in a lot of situations, because even in communities where we are ostensibly so autonomous and so individualist, none of us are making these medical decisions in a vacuum. We are considering our families, we are considering our friends and our jobs and our communities, etc. So even when people assume there's this autonomy, and even if they assume there's financial empowerment, maybe you've got the money, but you don't have the transportation. Maybe you don't have the childcare. There's a lot of reasons why it's not really fit for purpose as a principle, even outside of that context. So just wanted to acknowledge that's obviously a fantastic insight, and something that we really want to be moving forward in bioethics and addressing that weakness. So I hope Rohan is still on the line. Did you have things you wanted to add?
Well, not just things, but thoughts for people from India. You know, we have now been seeing proposals to privatize district hospitals and government-run hospitals. And, you know, since today morning, at least, I've been thinking about what this is going to mean for dialysis patients, and if it's, again, going to turn something that is more evasive and inaccessible to patients. And what does that mean for those of us that think about truth-telling and the ethics of telling patients whether or not? Because the moment you are going to hand over these government hospitals to private players who are going to be running them for profit, would you be seeing doctors not telling patients about these simply because they know that the patients won't be able to afford them? Or do you think that the doctors will actually tell patients about these treatments so as to cause greater moral distress? I don't know, it's just a lot of questions I have in my mind, not necessarily making coherent sense.
Thank you, Rohan. We have rounded up the presentations and the discussions. Now we have a solid 20 minutes for audience interaction and questions. So shall we have an open house now? Anybody from the audience wants to say anything? Please raise your hands and we can. So to kickstart the discussion, I wanted to just ask a very, very interesting thing that I noticed in Dr. Ali and Dr. Shekhani's paper was that you had brought out the issue of religion and how religion had been a very good social support system during the in decision making and in treatments. Could you very briefly elaborate on that? What?
All right. So while it was not investigated very much deeply, but with this idea that when Dr. Ali was talking about the problems that they've experienced, what really emerged was you couldn't see suicidal thoughts, for example, within or any kind of thoughts of harming oneself, despite so many issues that they obviously faced, right? And when asked, and we quote that in the case studies as well, is that no, we have belief in Allah, and and this is my lot. So there was this acceptance that this is fate, and this is what my destiny from God essentially is. So religion, and there's a lot of work done in Pakistan on that already, that religion appears as a major coping mechanism for a variety of different illnesses, whether it's cancer, whether it's dialysis. And I think that's what we were alluding to. Do you have anything to add?
Yes, exactly. There are a lot of parents that I counsel with hereditary diseases like Lawrence-Moon-Beadle syndrome or diseases in which children are born with a lot of deficiencies, and then they grow up to become more dependent, and they all die in an adolescent age. And yet the parents don't want to stop, or they don't quit, or they don't just say, knowing very well that the risk is very high of having similar child again. They always put all the burden on their fate, and they always have a very strong faith and say that if this is what my children are going to get, I'm fine with it because this is my God wants me to go through, and he will reward me for this. So these kind of beliefs, we think that has some significant, some people may argue that this is lack of rational thinking or education, or their approach is faulted, or whatever we may say, but this is the fact of the community that we are living in. There are, not everyone is like this, but there are quite a few people, and especially this troubled, chronically sick children's families. We see quite a few of such parents who are very content with whatever share they've got from their life.
Valerie, you want to say something?
Thank you. Yes, just briefly, Professor Ali, I think one thing that struck me in your paper that I thought was great that you collected the data was that sometimes siblings are taken out of school permanently. And I think this is also very, very challenging for me, because I think, that child's family, everybody that is dependent on that child for the rest of their life will be impacted on that. So I find, first of all, I really believe that we should all be advocating that the government somehow find a way to meet the needs of dialysis, because it is so common in the population. But, I just wonder how, do you get to the level of actually discussing not only the financial toxicities, but the toxicities on the other children, which are unanticipated or unseen at the beginning potentially?
Yes, looking at these siblings getting affected in such families, the initial thought came from my reading from England, where they had interviewed the siblings of 31 children who were receiving dialysis. And all these children were really very anxious, were not getting to that maximum potential, and were always worried, had a fear of unknown, and they wanted to grow up quickly to help their parents cope with all the pressures. In our culture, with this poverty and these resource constraints, you know, the children were removed from the schools, not only for financial reasons, but also if the mother had to be out to the hospital, there would be no one to take care, to bring the children back and forth from school. And after coming back from school, if they would, there would be no way to bring the children inside home, you know, and they would be sitting in the neighbor's home, or they'd be wandering on the streets. And so that social burden was so much that it was thought that it is better that these children would just go for some kind of technical or skill education somewhere rather than going to these regular schools.
But I think that also has to do, and of course, this whole perspective, but Dr. Ali's perspectives there, absolutely, that's probably one of the reasons why children dropped out of school. But the quality of education and public sector education in Pakistan is also quite horribly low. So that could be one of the potential factors where they're like, okay, so this education really isn't going to benefit my child, so might as well put him in vocational training or skills-based training where he's going to learn a skill and actually able to earn income for the family, which is already strained because of multiple reasons and because of dialysis. So I think that was also contributing a role over here in the school dropout.
Supriya, could you unmute yourself? And
thank you, Vijay. This is all amazing conversations, which keeps bringing up my whole doctoral work on informed consent when I started looking up in India. And so the 2 points which I wanted to just bring for the floor is, like, first, the idea of informed consent doesn't exist in Indian legal system. So we emphasize, the discussion is much more on real or valid consent. What does it mean for clinical decision making is the doctors decide what's best for the patients, right? That's what it happens. So there's, of course, a social context which plays out, and brilliantly you all have highlighted this, like how social, for example, poverty or the resource crunch, which plays a significant role in how the patients make a decisions, or the doctors help or facilitate the patients to make certain decisions. So, and as Ivy, I think I got it right, the name, as exactly you pointed out, whether it's East or whether it's in India, the West or East in that conversation, if I want to move with the dichotomous understanding, I think it's more about the social context wherever we are. And as you said, we are not in a vacuum, right? So it does play out. So in ethics discussions, in bioethics, people talk about relational autonomy these days, but still, I feel there is still a lot of conversations which we need to go beyond autonomy or relational autonomy conversations, but acknowledge the value of relationships and how decisions are also very relative in itself to whether it's a dialysis or everyday decision making within the healthcare context. So, so this makes me question, I think one of Valerie was talking about the choice, whether patients or people in India or any resource restricted or constrained settings, do we have real choice? I would put it as more like all of us, wherever we are in whichever part of the world, do we actually have an idea of real choice? We are always influenced by certain different perspectives, different contexts. So what does it mean for us? I think that's where I think we need to keep engaging. That means the social net, like India should focus more on universal health coverage, protect and make sure the vulnerability of patients are captured well in our policies and decisions, like any context. That's what I was thinking about, but yeah, thank you.
Evie?
Yeah, I just wanted to respond. It's a fantastic point. So I absolutely agree with you. This is a universal thing. None of us are living with perfect autonomy. And I would argue that basically none of us are giving truly informed consent for things, because, like, if I were in a situation where I needed to consent to dialysis, I'm not a nephrologist. I didn't spend years training. So all I can hope for is sufficiently informed consent in alignment with my personal values so that I feel like I'm making the choice that's in my own best interest. But deep down, I'm never going to really understand absolutely everything about my medical treatment across the board. So when we have these standards, particularly in bioethics, where we say the person has to have all the information, they're never going to have all the information. So realistically, when we're actually doing this, we talk about what's important to the patient to know that would actually influence their decision. So what's in line with their personal values and what information is likely to be relevant to them. So obviously we wouldn't tell them about every single possible thing that could happen that has an extreme possibility because it's not immediately relevant to their decision-making sort of ability there. But again, I think the best we can hope for is that we have, sufficient autonomy and sufficient sort of informed consent, because it's never going to be perfect regardless of where you live. So I think obviously you've made a fantastic point there.
Thank you, Evie, for that comment. To just add on to that, I'm not a nephrologist. I don't deal with kidney patients. I mean, patients with kidney diseases. But as a primary care provider, getting informed, providing consent, providing options to the patients about various treatment options and all the details and obtaining consent is quite a challenging process. And many times in low resource settings, we find patients who tell us, you make the decision for us. You tell us what is the best option. What should I do? What is my next step? And so I think informed consent and autonomy are one stage after. First, I think before informed consent and autonomy, it is more like looking for access to treatment. Where is the treatment available? Is the treatment available at all? And how do I negotiate and how do I get this patient to the treatment? And like, for example, I work in a primary care center, which is 80 kilometers away from a dialysis facility. And I have an adult patient on dialysis. And my everyday issue is not just to inform him about everything. When he was first diagnosed, the issue was not about informing him about the diagnosis and telling him about the options of dialysis, but even figuring out which is the closest dialysis facility and what is the access and how do I get this patient to that place. And I think those are even more fundamental basic issues, access to dialysis, like how all of you are talking about about Supriya's point about universal health coverage and the implications of that. And then the next layer, I think, would be information provision and engagement with the patient and the family. And yeah, Dr. Ali.
Yeah, I just wanted to elaborate on the same point that you were saying. I personally believe that the person who is taking that informed consent, his own belief and his own understanding or whatever his choice has a significant bias on when they are giving all these treatment options. For example, if I want to withhold life-saving treatment, the way how I will port the case to the parents or the consenting person has a significant bias. If I say, look at how miserable he is, and we don't think that he will make it anyways. So why don't we just stop this treatment? Versus, I think he still has a chance. He has a treatable condition. He may get back to his baseline. You're saying the same things, yet it's your own personal choice that voices it so differently that the person who is listening to you is more inclined to take your way. So I think the physician's bias can never be excluded from all these informed consent.
And I think, Supriya, not the bias bit, but like this whole idea of how family-patient interactions kind of play and physicians' interactions kind of play out in real clinical settings. And maybe it may not be as obvious as Dr. Ali paints, but yes, what physicians believe and how physicians align the goals of treatments kind of do influence that. And Supriya actually talks about that in her doctoral work with informed consent, as well as micro inequities that kind of seep into the conversations between patients and physicians and their family members. So physicians can direct the course, the way the treatment pans out. Because it links to the second paper, it's that not to say that patients should not be offered the choice, but really how the choice is presented to them and whether it actually is a choice at all. Because on this basic ground, at SIUT, everyone has a choice. Everyone has access to the treatment. But going beyond that, I think that's the real the issue of informed consent.
Priya?
Just 2 quick points. One was, in addition to, it's a continuation of what Professor Ali was saying. I think it's actually a burden that we carry as physicians and healthcare providers, because what we say influences decision making. And I think that really has much more of a role, maybe in low resource settings than in high resource settings, where the focus entirely is on patient autonomy. Here we function as a guide, and so while that may play a role, it's also very difficult for healthcare providers to sit with each patient family, and it's much easier to say you have this choice or you have that choice, and this is the cost, and you can decide if you want to hear more, and if you don't, that's fine. And if you now make a decision, it is much more difficult to get involved. Invariably, we ask them about their family, what they do, how many children there are in the home, and then come to some sort of the goal is actually to help the family decide on their own. But it's a process that goes in stages, and it's always along with the family, rather than advising them or stopping short if the family doesn't want to hear further. Sometimes the family is just too overwhelmed and they can't take it anymore. And that should not be taken as a sign that they don't want the treatment. We just have to back off. That's generally in our experience. Have to back off and say, we'll talk to you tomorrow. And see whether they actually want to hear more tomorrow or not. So that's sort of how things run in where we work in low resource settings. The second thing was actually that this limitation of autonomy of caregivers, because I work with kids, oftentimes what we actually find is that the lack of awareness of the disease and the possible treatment options in the community, and it need not be parents themselves or the caregivers, actually extended family, grandparents, who actually, I don't know whether this is limiting the parents' autonomy, but they actually tell them that this is treatment that's never going to work and don't waste your time. And so I feel that sometimes our parents, who are mostly young, come to us with this advice already being given to them. And so really has society and has the community limited those caregivers' autonomy far more than, say, a paternalistic medical decision making. Those were my 2 points.
Thank you. Veena had her hand up, but Veena Shatrugna? I think she's not on the call anymore. Okay. Is there anything else anybody else would add? We might just have a minute more. If not, thank you very much for this very, very fruitful first episode of the Authors Webinar series. It's been a delight to hear both the papers and the discussants' thoughts on these papers. We hope to continue doing this every quarter, and we will keep you posted about the meeting for the next quarter. Thank you very much for the active engagement, and see you all again in the next edition of the Authors Webinar series. See you.
Thank you. Thank you very much.
Thanks.
Bye, everyone.